The three primary indications for parent artery occlusion are in the management of large internal carotid artery aneurysms, especially in the cavernous segment. For dissecting aneurysms, usually because the vessel is too friable or there is hardly any flow distal to the dissection. For mycotic aneurysms, where at times again you cannot cross the aneurysm, and coiling the aneurysm would mean losing the parent artery itself. Now, before we treat an aneurysm in the internal carotid or in the vertebral artery, it is mandatory that we perform a test occlusion. And the next few slides will tell us the protocols that are necessary for performing a test occlusion and the complications associated with a test occlusion. So the protocols we would use is to perform a full 4-vessel cerebral angiogram. We would assess the PCOM and the ACOM. We look at a carotid bifurcation to ensure there are no plaques over here. We have sheaths in both groins. The reason is that once you test occlude, then you have a balloon in one carotid artery and you have to inject into the opposite carotid or the vertebral, and thus you will require 2 sheaths and 2 access points to do this procedure. I prefer to have a guiding catheter in the target vessel and through which I take the balloon, because it allows me to inject into the common carotid and assess the external carotid artery along with the test occlusion. I prefer to inflate the balloon under roadmap with frequent injection through the guiding catheter, so I'm sure I do not overinflate and induce a dissection, because if the patient fails to test occlusion and we have a dissection, then we can have a major stroke. We keep the balloon inflated for at least 15 minutes, provided there are no deficits. Heparin is given as a bolus of 5,000 international units. We inject into the common carotid with the balloon inflated to see filling of the aneurysm through the external carotid artery. We inject in the opposite internal carotid and vertebral artery to assess the cross circulation and filling of the aneurysm, and to see the venous drainage, which is again extremely important, so that we know that the patient can tolerate a permanent occlusion. What is the neurological assessment? We have an independent neurologist to do the assessment. They assess for power and sensation skill, continuously ask questions, do a complete neurological examination every 5 minutes and definitely at the end of 15 minutes. Ask the patient if they are experiencing anything different during the procedure. If you are doing a test occlusion in the posterior circulation, ensure you have a watch over the respiration and the heart rate. You may suddenly find the patient develops a respiratory arrest because brainstem can get hyperperfused. In the carotid, we do not test occlude over the carotid bulb. We may have a bradycardia, and we have to reassess the patient also after deflation to ensure we have not induced any form of ischemia. Sometimes we may have a patient who is under GA and then we decided test occlude. So how do you assess? Here the important thing is inflate the balloon, inject through the opposite carotid and look for the venous drainage on the culprit side or the ipsilateral side. So if the venous drainage on the opposite side is not delayed to more than 3 seconds, or rather it should be less than 3 seconds, and then you can be reasonably sure the patient won't have a neurological deficit. So what we do is look at the venous drainage when it appears on the side of injection, look at the venous drainage on the side of the aneurysm with test occlusion and see the delay. In most patients you'll find the delay is not more than 1 second. What are the complications? You can have an arterial dissection which may be symptomatic or asymptomatic. You may have transient or permanent neurological deficit because of a small plaque or an emboli that's gone up. And of course we can even symptom have death, especially if it is in the posterior circulation, and common complication associated with any percutaneous procedure on the groin that is having a hematoma. So just let me give you an animation about the whole procedure. This shows an aneurysm in the internal carotid in the cavernous region. You can see the posterior communicating artery and the anterior communicating artery. So we inflate the balloon, the aneurysm stops pulsating, but this is the time you start a neurological assessment. During the same time, you would inject into the opposite carotid and the vertebral artery to ensure that the communicating arteries are patent and there is good filling of the opposite side. So you have a look at the anterior communicating artery, have a look at the posterior communicating artery. Sometimes you find that when you inject from the opposite side, just the opposite ACA fills up, but the MCA doesn't. And you make an injection in the vertebral, you find the MCA is filling from the posterior communicating. So it's important you make a study in both vertebral and anterior communicating arteries before you finally decide to do the procedure. Another reason why you will have to do the procedure is so that you can see whether the ophthalmic artery is filling the aneurysm. So if the ophthalmic artery is filling the aneurysm, obviously the treatment will be a little different than one in which it's not filling. Sometimes you'll also notice that the filling of the aneurysm actually takes place from the posterior communicating artery, and then again you have to ensure that the aneurysm is partially packed or completely packed before parent artery occlusion. Otherwise it will recanalize. Not only recanalize, it tends to throw emboli into the circulation and the patient may develop a stroke. Here is an example of a patient who's come with ptosis and who's got ophthalmoplegia. The angiogram shows the patient to have two aneurysms in the right internal carotid, one in the cavernous segment and one in the extracranial cervical ICA. The test occlusion shows good filling from the left carotid system and also filling of the MCA from the vertebral system. But nowhere during this is the aneurysm opacified, either from the ECA or from the vertebral system. So we go ahead and make it permanent by placing multiple fibered coils, and we have cured the patient of the procedure. Now we have a situation we talked when the external carotid will fill the aneurysm even after test occlusion. Have a look at this aneurysm. It's a partially thrombosed cavernous segment aneurysm, or a little higher. Actually it will be more like a supraophthalmic aneurysm. This is a test occlusion. You do not see the internal carotid at all, but the external carotid, as you see, is opacified and the aneurysm is also opacified. So this is what we are saying can happen if the external carotid can retrogradely fill the aneurysm. So the treatment of this is a little different. We would put coils into the aneurysm, then pull out the coil so that the origin of the ophthalmic artery is taken care of. Now retrograde filling of the aneurysm does not take place through the ophthalmic artery, and that makes it a permanent cure. So here the end results in the AP and lateral demonstrating that aneurysm does not fill though the parent artery. This is the third situation we talked about, where the aneurysm fills from the posterior communicating artery. Here is an aneurysm. It's in the carotid-cavernous segment, and this is a test occlusion with the balloon inflated. When you take an AP, everything looks perfect. But when you take a lateral, you can see the aneurysm filling to the posterior communicating artery. So what we did was we put coils into the aneurysm, also put coils in the parent artery just to ensure that the aneurysm does not recanalize at all. So here is the injection made into the vertebral artery, showing the ICA filling through the posterior communicating artery with no longer any filling of the The last situation where we would do a parent artery occlusion with a test occlusion would be a situation like this, where we have an aneurysm which is in the ICA top. You would place a stent, then take a catheter across it and occlude the aneurysm as well as the proximal part of the first part of the ACA, which is the A1 segment. So now we have kind of cured the aneurysm, but cross circulation takes place from the anterior communicating artery. So that is to conclude all the therapies that are possible for aneurysm treatment, and we talked about the guidelines, the protocols, the problems of aneurysms, how to plan a simple aneurysm where the neck is not wide, and how to plan treatment for a wide neck aneurysm, and finally, of course, what are the treatment options in an aneurysm where you think you have to sacrifice the permanent artery.